You were stopped in traffic when the car behind you did not stop. They x-rayed your neck, told you nothing was broken, and sent you home. That was 4 months ago. You still cannot check your blind spot without turning your torso. Your MRI was unremarkable, and somewhere between the third visit and the fourth, your chart changed language, from injury to complaint, from patient to claimant. I am Dr. Padda. I run the Padda Institute Center for Interventional Pain Management in St. Louis, and I see the people this injury does not release. This system fails you at both ends. Most whiplash resolves. 6 to 12 weeks of analgesia, early movement, graded exercise, and return to normal activity. Inside that window, no procedure is indicated, and a clinic offering you one is selling you something. The second failure walks into my clinic at month 4, where the assembly line offers exactly 2 exits. Behind the first door, the images are normal, therefore the injury healed, therefore what remains is stress, litigation, or catastrophizing. Behind the second, serial injections chosen by body region rather than diagnosis. A trigger point here, a steroid there, because the neck is where the needle goes. Both doors share the identical defect. Nobody made a diagnosis. A normal MRI does not tell you your neck is fine. It tells you there is no tumor, no cord compression, no disc on a nerve root, no gross ligamentous disruption. It is not the study that excludes a non-displaced fracture that is a CT. If nobody ordered one, say so out loud. Whether a fingernail-sized joint capsule is generating pain traffic is not a structural question. It is physiological and needs a physiological test. Now the mechanics, between 50 and 75 milliseconds after impact. Before your neck muscles can generate useful protective force, the seat drives your torso forward and your head stays behind. The cervical spine assumes a transient S shape, lower segments extending while the upper are still flexed. Only past 150 milliseconds does the neck swing into simple extension. That early S shape, not the later swing, loads the paired zygapophyseal joints, the facet joints. Cadaveric and computational models show capsular strain rising above the capsule's physiologic range, enough for what the biomechanics literature calls subfailure injury. At collision speeds, people survive without breaking a bone. Subfailure is the precise word. Loaded past the point of damage, without tearing through. That mechanism is modeled, not measured in you. The dorsal horn sensitization invoked alongside it is rodent work. I will not dress laboratory inference as bedside proof. What has been measured is prevalence. In 1996, in spine, Lord and colleagues studied 68 consecutive patients referred with neck pain persisting beyond 3 months after whiplash, using comparative and placebo-controlled blocks. 60% had cervical facet joint pain, 95% confidence interval, 46 to 73%. That is the yield in a referred population that had already failed to recover, one that included headache-dominant patients screened first at C2 to 3. Not the rate among everyone in a collision, and not a pure axial neck pain number. The controlled evidence I'm about to describe was generated in axial neck pain, not headache, and I will not stretch it there. First, close the differential. 2 things come off before anything else because they are what hurt people. Sudden severe neck or back of head pain after a collision with dizziness, visual change, drooping, or slurred speech is a cervical artery dissection until a CT or MR angiogram says otherwise, an emergency department, not a pain clinic. Ongoing headache, fogginess, light sensitivity, or trouble holding a thought is concussion. A brain injury managed on its own track, and no needle in your neck addresses it. Radiating arm pain with weakness or reflex loss is radiculopathy. Gait change, hand clumsiness, hyperreflexia is myelopathy and urgent. Occult fracture and craniocervical instability must be excluded first. When the picture is axial neck pain, worse with extension and rotation, tender over the articular pillars, no neurologic deficit past 3 months, the facet joint is a testable hypothesis. We test it with diagnostic medial branch blocks. From C3 to 4 downward, each cervical facet joint draws its supply from 2 medial branches, above and below, wrapping the waist of its articular pillar, reachable under live fluoroscopy with a fraction of a milliliter of anesthetic. If that joint is the generator, your pain stops for the pharmacologic life of the drug. C2 to 3 is the exception, supplied by the third occipital nerve, which crosses the joint itself rather than a pillar waist. It is blocked and lesioned differently, with its own risk of temporary unsteadiness. One positive block is not enough. Single blocks carry an unacceptable false positive rate. We use dual comparative blocks, short-acting on one visit, long-acting on another, and your relief must track the agent. Here's the sentence that costs this practice money. A negative block means no procedure. If the joint does not answer, we do not burn it. When the blocks are concordant and positive, neurotomy becomes an option. Under fluoroscopic guidance, the electrode is laid parallel to each medial branch, parallel, because the lesion forms along the shaft of the active tip, not across it. The tissue is heated to approximately 80 degrees Celsius. It denatures the nerve carrying that joint's pain traffic, symptomatic denervation, not repair. No steroid is involved at any point here. And no corticosteroid preparation is FDA labeled for epidural or intraspinal use anywhere in the spine. That is off-label, whoever does it, and you are owed that sentence before a needle goes in. Anyone calling neurotomy healing is not describing this procedure. In the New England Journal of Medicine, also in 1996, Lord randomized 24 patients with axial post-collision facet pain to real neurotomy or a true sham, current never switched on, patient and assessor blinded, median time to return to half of baseline pain, 263 days treated, 8 days sham. In 2016, in Pain Medicine, Engel and the Standards Division of the International Spine Intervention Society analyzed the data. The majority pain-free at 6 months, more than a third at 1 year, number needed to treat 2. They graded effectiveness, high quality, conditional on meeting their own technical standard. They graded the evidence on risk, low quality. I report both because they publish both. A number needed to treat of 2 means roughly half of correctly selected patients get no complete relief. The material risks are numbness in the treated territory, post-neurotomy neuritis that can burn for weeks, transient unsteadiness after third occipital neurotomy, deep paraspinal weakness, new or increased pain, bleeding, infection, and rarely nerve injury. It is also not permanent. Peripheral nerves regenerate. Benefit typically ends between 6 and 18 months, and repeat treatment is expected. If nobody told you that, you were not consented. You were recruited. Movement and deep neck flexor retraining hold the result. You may have been offered a ketogenic protocol, an omega-3 pro-resolving mediator, or red light therapy for this neck. What stands behind them for whiplash specifically is cell culture and rodent work. No controlled trial has shown any of the 3 shortens a whiplash-associated disorder or improves a facet-mediated neck. They are adjuncts under study, not treatment for what happened in that collision, and I will not bill you as though the difference did not exist. What I'm about to describe is a composite, a picture assembled from many patients with this condition, not one person's chart. 5 months after a rear-end collision, axial right-sided neck pain, worse with extension and rotation, no arm symptoms, normal exam, unremarkable MRI. Comparative blocks followed. A short-acting agent gave a little over an hour of near-complete relief. Weeks later, a long-acting agent gave most of a day. Longer relief with the longer-acting drug, concordant. Only then did we discuss neurotomy. The hard parts are the ones nobody advertises. Authorization took weeks. The first fortnight afterward was worse, not better. Burning, patchy numbness, neuritis, and a message wondering whether the nerve had been damaged for good. Relief settled in during weeks 3 and 4. Around 10 months, the ache returned as the nerves regrew, exactly as predicted. That is a good outcome. It is not everyone's outcome, and roughly half of properly selected patients do not get relief that complete. If your neck pain has outlasted 3 months since your collision, the next step is not another injection. It is a diagnosis. Start at painmd.tv on the car accident injuries page with your imaging and timeline. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902. Monday through Friday, 8 in the morning to 5 in the afternoon. Bring me a hypothesis we can test. If something in this changed how you understand your own pain, that was the point. Bring us your imaging, your history, and your questions. Padda Institute Center for Interventional Pain Management. We are at 4477 Woodson Road, Suite 100 in St. Louis, Missouri, right next to St. Louis Lambert International Airport, and at 12174 Natural Bridge Road in Bridgeton. We serve the St. Louis region, Missouri, and Illinois. Call 314-481-5000 or text 314-886-5902, Monday through Friday, 8 in the morning to 5 in the afternoon. Everything in this video is education, not medical advice. Ask for the diagnosis before you accept the procedure.